Off you go. Take it away.
Awesome. Welcome, everyone. Thanks for coming along to your second day of revision lectures. I'll start you off with head and neck. And as you all know, it's a little bit of a big topic, but hopefully I can take you through and give you the general gist of everything that you need to know. These are my references. A lot of them came from my own slides with the PSP. So I've, taken out some of the details of those ones, but also I would have to credit my friends Alina and Gavin for their lovely slides as well. And this is the structure to give you a general overview of how I'm going to cover everything. We'll go through the head first, the bones and the muscles and everything like that. Then we'll go into the neck and how that kind of relates. And then we'll do the vasculature of the head and the neck because they're kind of joined together. And then we'll do all like the innervation. And then we'll do the special bits, so the eye, and then all the bits that are connected, like your nose, your mouth, your ear, your pharynx, your larynx. And then we'll finish off with embryology. One thing that we're not covering is clinical skills. So I would just recommend you go over the head and neck exam. Am I hearing audio from someone? Maybe just make sure you're muted. Awesome. We'll start with the head. So this is the skull. Hopefully you know this okay-ish by now. You've got your neurocranium and your viscerocranium. So your neurocranium is composed of your frontal bone at your front, your ethmoid over here, which kind of makes the inside of your nose mostly, your sphenoid, which is difficult to see, but it's on the inside and it comes out just at this area here, your occipital bone, your temporal bone, and your parietal bone. Some of them you only have one of, like your midline ones, and then some of them are bilateral. And then you have your facial bones or your viscerocranium, and that's made up of your nasal bone, which is tiny, it's kind of in your nose at the backish, your lacrimal bone, near where you cry, I guess, your palatine, which makes up your hard palate up the top of your mouth, your zygomatic bone, your vomer, also in your nose, your inferior nasal concha, which is a separate bone. The rest of them come from your ethmoid, and then your maxilla and your mandible. You've got a couple sutures where these things join. So you've got your coronal suture at the front, like this, your sagittal suture going down midway, and then your lambdoid suture at the back. And where these sutures join, you have your bregma at the front and your lambda at the back. This is your ethmoid bone. So the most important part of the ethmoid bone is your cribriform plate. And that's where your olfactory nerve fibers or your first cranial nerve fibers go through from your cranial cavity into your nose and lets you smell. You can see it's got all these other bits and pieces, but it's not too important. It is important to note that you can see that it forms the boundary kind of between your brain or your cranial cavity, your eyes and your nose and like your maxillary sinuses. So if you have a CSF leak, it can actually leak into your nose if it breaks through the cribriform plate. This is your sphenoid. It's in your middle cranial fossa, as you can see. So it's kind of the back of your nose. And so you can actually sometimes do surgery through it like that, through your nose into your brain. That's how it works. You can also see it's on the side here. And this is kind of your middle cranial fossa. Yeah. These are the parts of the sphenoid. You've got your greater wing, your lesser wing, your body, and the pterygoid processes. The main thing to know about the greater wing, I would say, would be the foramen. So you've got your superior orbital fissure kind of between your lesser and greater wings. And then you've got your foramen rotundum, ovale, and spinosum, which is the little one. And we'll go through these a little bit more later as well. Your lesser wing divides your anterior and middle cranial fossas. And then the body, I'd say the most important two parts to know would be the sella turcica, which contains your pituitary gland, as well as the chiasmatic groove, or chiasmatic sulcus, and that's where your optic chiasm is, or your second cranial nerve, as it goes kind of into the optic canals there into your eye and lets you see. Your pterygoid process is less important, but you have two plates. You have a medial plate and a lateral plate. Your medial plate acts as a pulley for the tensor veli palatini, which pulls your soft palate up. Your lateral pterygoid plate is an attachment site for some pterygoid muscles. And you've got a canal as well that opens into the pterygopalatine fossa. Not too important to know the details of that, but cool to know that exists. This is your temporal bone. You've got a couple parts to it. This is your squamous part where your temporalis muscle sits. You've got a zygomatic process, so that's kind of your cheekbone, and that goes into your zygomatic bone. You've got a tympanic part, so tympanic for air, so it makes sense that your air hole is there, scientifically known as your external auditory meatus. You've got your styloid process where muscles that go stylo something attach, and you've got your petromastoid. And this is more important. So you've got your mastoid process made up of mastoid air cells in there, as well as a petrous part, which makes the boundary between the middle and posterior cranial fossa. And we'll get back to this again later as well. This is your maxilla over here, kind of making up this part of your face. And these are the three main canals in them. You've got your incisive canals by your incisor teeth at the front. And there are two things that run through, or two-ish things that run through here. You've got your greater palatine vessels and your nasopalatine nerve. Your nasopalatine nerve runs from the inside of your nose through this incisive canal into the top of your mouth, or the roof of your mouth. So it forms kind of a channel between your oral and nasal cavities. And then you've got your greater and your lesser palatine foramen. Both of these come from a palatine canal and comes in to supply your palate. So your hard palate is at the front and your soft palate is at the back. So at the front, you've got your greater palatine foramen, and these vessels and nerves run kind of across all the way to the front and then into your incisive canal and kind of goes into your nose. And that's why your greater palatine vessels are also through the incisive canal. Your lesser palatine, like nerve, artery, and vein, go from your lesser palatine foramen towards the back where your soft palate is. And then you've got all these like little bits and pieces, which you don't really have to know as well. This is your mandible. As you can see, you've kind of got a body and a ramus. On the ramus, you've got your condylar and your coronoid process. So your condylar process, to me, the word sounds a bit more like a wheel. And so I'm like, oh yeah, it'll be rounder, so it's part of a joint. So it's at the back. So that forms your TMJ, or temporomandibular joint, or your jaw kind of joint with the temporal bone. And then you've got the coronoid process where the temporalis muscle attaches and lets you kind of, chew and things. You've got a mandibular foramen over here, which goes into the bone, forms a mandibular canal, and then ends at the front as the mental foramen here. So what goes into your mandibular foramen is your inferior alveolar nerve, which comes from the third branch of your trigeminal. And that supplies your teeth as it goes through, as you can see. So you can kind of imagine it going like underneath your teeth. And then it comes out your mental foramen and it's renamed the mental nerve, and it kind of supplies the front of your chin here. The mylohyoid line, or like this line, is where the lingual nerve is, as well as kind of like the nerve to the mylohyoid. So with lots of dental procedures and things like that, you can accidentally hit the lingual nerve instead of the inferior alveolar. So the TMJ, it's a synovial joint. It's formed by, as we mentioned before, the head of the condylar process of your mandible and the tubercle of the tympanic part of your temporal bone. You've got a couple ligaments, lateral, sphenomandibular, stylomandibular, not too important. And it's covered with fibrocartilage and divided into two by an articular disc in between. So it's not just like articular cartilage to articular cartilage. It's really important to know your muscles of mastication. So your masseter, your temporalis, your medial and lateral pterygoids. So masseter, temporalis, and then these are your medial and lateral pterygoids. All of them develop from the first pharyngeal arch, and they're all innervated by V3 or your mandibular nerve. And it's important to know how they move. We've had exam questions on this before. All of them elevate except the lateral pterygoid, because it's kind of like horizontal because it's lateral. And so that kind of moves your jaw side to side instead. And it also does some protraction. Your temporalis muscle also retracts the jaw because it attaches to the condylar process. So that's kind of how I think about it. I would just generalize and then think about the exceptions. You don't have to know this very well, but I think it helps orient you a little bit. Your temporal fossa is right here. It feeds into your infratemporal fossa, and then that goes into your pterygopalatine fossa, which is kind of like behind here. And your pterygopalatine fossa is really complicated, so they're not going to expect you to know it that well, in my opinion. I think we've had one question on it maybe. It communicates with your nose, your eye, and your middle cranial fossa. Your maxillary nerve and artery runs through there, and you've also got a ganglion there. So just know that lots of things are happening there. It's kind of the point of communication of a lot of things. Cool. This is the floor of your neurocranium. It's made up of a couple bones, as we mentioned before. So like your frontal, your ethmoidal, your sphenoid, your temporal, your parietal, and your occipital. It's divided into your anterior, middle, and posterior cranial fossa at the lesser wing of the sphenoid and the petrous part of the temporal bone. And it's got your cranial foramina, which is here. So this is the bare minimum of what you should know, and this is kind of like the maximum of what you could know. So we'll go through the bare minimum today. The first foramen that you should definitely know is your cribriform plate, part of your ethmoid bone. It's got all these little holes for your first cranial nerve. Okay. And then your second one is your optic canal here. So that's part of your sphenoid. It holds your optic nerve and your ophthalmic artery. The next thing is your superior orbital fissure between your greater and lesser wings of the sphenoid. And this holds all the other nerves to the eye, so 3, 4, and 6, as well as some sensation. So the first of your trigeminal nerve, as well as your superior ophthalmic vein. And then you've got rotundum with your second trigeminal nerve, your ovale with your third branch, and then your spinosum with your middle meningeal arteries and veins. Your carotid canal, which is the next kind of big one, has your internal carotid artery. It's in the name, perfect. Your internal acoustic meatus. So the way to think about this is it's acoustic, so it needs your vestibulocochlear nerve, or CN8. And because it has 8 and everything's in kind of order, it also has your facial nerve, CN7. The next one is your jugular foramen. 9, 10, and 11 are in here, as well as a couple venous sinuses from your brain, which I'm sure Gavin will touch on in neuro, flowing into your IJV. And then you've got your hypoglossal canal with your hypoglossal nerve, nice, and your foramen magnum with like your brainstem and everything like that. Cool. This is your scalp. I like the mnemonic because it's literally just scalp. So the 5 layers you should remember would be your skin, your connective tissue, your aponeurosis, which is made up of your occipitofrontalis muscle. And the main thing to know about this is because it's made up of the muscle and you've got this constant tension, it means that the superficial scalp wounds, which don't cut through this, won't gape. But the things that do cut through this will gape because of that constant tension pulling them apart. And then you've got loose areolar tissue in your pericranium, which is like like periosteum, so the layer that covers your bones. Arteries are in between the first and second layer, and these three layers move as a single unit. So if you like kind of move the skin on your scalp, that's these three moving. It's innervated by your trigeminal nerve, kind of on this part, and this part, and this part, and then your cervical plexus for the rest of it. And you've got internal and external carotid branches supplying it. Yeah, mainly internal at the front-ish more, and then external at the back. I'm not going to go into all the facial muscles, but the main point is they all develop from the second pharyngeal arch, so they're all innervated by the facial nerve, and you've got 4 groups. So you've got the orbital group, which is actually like smaller. So you've got your orbicularis oris, and you've got your corrugator supercilii, which like makes you frown. You've got a nasal group, which some of them, you know, like depress them. And then you've got your oral group, which I learned. I don't think you have to learn it that well, to be honest, at all. So like if you have lots of time, learn it. If you don't have lots of time, don't learn it. But I learned it from 12 to 6 o'clock because it kind of goes like in a circle. Generally like levators or elevate, and like depressors or depress, etc. The other group is pretty fun. Your platysma is this huge muscle, so it's like, you know, some people tense their neck. That's that muscle. You have your auricular, anterior, superior, and posterior muscles, and then that's your occipital frontalis, making up the third layer of your scalp. So you can see these are the branches of your facial nerve. You've got your temporal branches, your zygomatic branches, your buccal branches, your marginal mandibular, and your cervical branch. And this kind of tells you what muscles it innervates. It's generally kind of just, yeah. Cool, that's the head. We're on to the neck, part 2. Relations and key features. Definitely know that the neck can run into the thorax or into the upper limbs via the thoracic or the axillary inlet. And the key landmarks that I remembered were C3 to 4 is where the common carotid artery bifurcates into the external and internal carotid arteries. And C5 and 6 is the transition where your between your larynx and trachea and your pharynx and esophagus. So, yep. These are your bones. So basically just your cervical vertebrae. You've come across them before. C1 is your atlas. You've got your anterior and posterior arch with no vertebral body. And a fracture of that is a Jefferson fracture. And remember that always goes through 2 things because it's connected. C2 is your axis. It's got your dens or odontoid process, which is also this part in this X-ray here. And then you've got your typical cervical vertebrae, which have a transverse process with your transverse foramen, and that houses, hello, that houses your vertebral arteries and veins, except for C7. And sometimes they test that, so not C7. And then you've got your vertebral body and foramen and a bifid spinous process where your knuckle ligament sits. Cool. These are the muscles of the neck. I know this looks very daunting, but this is all the muscles of the neck as well, if you stay positive. You've got anterior, lateral, and posterior cervical muscles. Anterior is the most important. Lateral is basically just your scalenes plus some other stuff. And then posterior, I wouldn't learn. So anteriorly, superficially, you have your platysma covering your entire neck. You have your sternocleidomastoid. So that's got your 2 heads from your sternum to your clavicle, and sternum to your mastoid and your clavicle to your mastoid. So 2 heads of your sternocleidomastoid. You've got your subclavius, which is a little muscle. And then you've got your hyoid bone. So your hyoid bone is kind of like, you can't actually feel it. It's a little bit too up there. But the ones above that will be your suprahyoids. The ones below that will be your infrahyoids. Of your suprahyoids, you have 4. You have your digastric, di for 2. So it's got an anterior and a posterior belly. You've got your mylohyoid, so molar to hyoid, which forms kind of like a bowl like is that bit. Your geniohyoid sits above that, closer to your tongue, and that's more like two heads running from your chin to your hyoid bone, genio for chin. And then you've got your stylohyoid. So that's where it runs from your hyoid bone to your styloid process. And then your infrahyoids are also pretty cool to remember because they're named from inferior to superior. So you've got your sternohyoid running from your sternum to your hyoid bone, and then your sternothyroid. So your sternum to your thyroid cartilage. Got your thyrohyoid. So kind of picking up where the sternothyroid ended at your thyroid cartilage, that runs from there up to the hyoid bone again. And then you've got your omohyoid, which kind of does this thing, and it wraps around the IJV and it attaches to the scapula. So to run through that again, kind of in this picture, you can't see all of them, but mylohyoid here, your digastric with the two. Geniohyoid would be above this, running like this. Yeah, sternohyoid here, sternothyroid under it, because it has to be under it because it only runs to the thyroid cartilage and you can't attach onto the cartilage if there's another one that runs all the way to the hyoid above it. Your sternocleidomastoid, your platysma. What else can we see? Omohyoid is doing a little sneaky here. It kind of runs like this behind everything. So that's your anterior muscles. And then laterally, you have your scalenes. They all originate from your transverse processes and then attach to either the first rib, as with the anterior middle, or your second rib, as with the posterior scalenes. So that's here. The main relations to know with this is what runs above the anterior scalene, more superficial to that, and what runs between the anterior and middle scalenes. So above the anterior scalene, you have your phrenic nerve, and you have branches of like this thyrocervical trunk, as well as your subclavian vein over here. And then behind that, so in between your anterior middle scalenes, you have your brachial plexus and your subclavian vein, artery, sorry. Cool. Nice. This is a cervical cross-section. If you chop someone's head off and you look in, it looks like this. You've got one superficial cervical fascia, and then you've got deep cervical fascia, which is split to a couple of things. So think pre-something means they contain something, because the people naming this were like, yeah, to get to this thing, you have to get through this fascia. So like this. So your prevertebral fascia will contain vertebra. Yep, so that's that there. And then you've got your pretracheal fascia. So to get to your trachea, you have to hit this fascia in the blue. This runs to the pericardium, which is pretty cool. And it contains a lot of like the midline structures, like your trachea, your pharynx, your esophagus, your thyroid, recurrent laryngeal nerve, right here, and some of your strap muscles. And then you've got your carotid sheath. Good to know all the contents in this because there are only 3 and they're kind of important. So common carotid, your internal jugular vein, and your vagus nerve. It's also pierced by the glossopharyngeal and the ansa cervicalis, but we can forget about that. And it's connected by the alar fascia. And then you've got an investing layer, which is the outer layer here, and that contains your traps, your muscle at the back, and your sternocleidomastoid, your 2 heads. So goiter is when your thyroid enlarges. So the symptoms that come along with that, you can think about with the things that are also kind of nearby. So with the trachea, you get cough and dyspnea as it compresses it. With your pharynx and larynx, you get dysphonia. So like not being able to speak properly. Esophagus, you get dysphagia, so difficulty swallowing. And then compression of like the IJV, you get Pemberton's. So that's when they raise their arms and they go pink and things like that. These are your triangles of your neck. You have an anterior and posterior triangles. Not too important in my opinion. The anterior triangles hold your midline structures basically. You can probably kind of imagine things like your hyoid, your larynx, your thyroid, esophagus. And then posteriorly, you have things like your accessory nerve, subclavian artery, and cervical plexus. So speaking of cervical plexus, this is it. You've got cutaneous and muscular branches. It's in the posterior triangle of your neck. So with your cutaneous branches, so these are the things that supply your skin, right? So you've got anterior and posterior rami, and they supply anteriorly and posteriorly. So your anterior rami include your lesser occipital, your greater auricular, your transverse cervical, and your supraclavicular, and they're kind of named pretty well, basically where it is. Your posterior rami has your greater occipital, C2, and then just kind of like C3, 4, 5, going down. Muscular branches, as you can see, it's a little bit, but the main two I'd say you should know at least is your ansa cervicalis, which is C1 to 3, supplying your strap. So your sternohyoid and your sternothyroid, as well as your omohyoid. And then your phrenic nerve, C3, 4, 5, keeps the diaphragm alive. So that's your diaphragm and pericardium. Cool. We're on to the vasculature now. Part 3. Arterial supply of the head and neck comes from the carotids, which is nice and simple. It's basically just one thing branching into lots of things. They come from your right brachiocephalic trunk and your aortic arch on the left, and then bifurcates at C4 over here, which is kind of by the upper border of the thyroid cartilage, into your external and internal carotid arteries. Your external carotid arteries go and supply your head and neck, and your internal carotid arteries supply your brain and CNS via the vertebral arteries. With the vertebral arteries, which arise from the thyrocervical trunk here, and they go up. So that has one exception, which is the ophthalmic artery, and we'll come across that a little bit later. And you can remember the branches of the external carotid through some attendings like freaking up potential medical students, which I'm sure lots of you have heard of already. So your superior thyroid, ascending pharyngeal, lingual, facial, occipital, posterior auricular, maxillary, superficial temporal. Of these, I wouldn't say you have to know them very well at all. No maxillary, because that gives your middle meningeal artery, which is involved in your pterion fracture. Your pterion is this area here, which kind of joins your sphenoid, your frontal, your parietal bones. And when you whack that, you're worried about an intracranial bleed. And the other one to worry about would be your superficial temporal, because that's involved in temporal arteritis. So a classical presentation with that is an old female with pain in her temples. She's like, oh, I can't comb my hair, it really hurts. She's also been getting this jaw pain or jaw claudication. She feels it's weird chewing, and she might have lost some vision. So when that happens, think temporal arteritis and be like, I want a biopsy of the artery. Venous drainage all eventually drains into your subclavian vein, and that goes into your subclavian via your external and your internal jugular veins. So your external jugular vein is actually the small boy, and the internal jugular vein is your big boy. So your external jugular vein, you can see here, it kind of drains from your retromandibular vein from some parts of the face. And then your internal jugular vein drains more anteriorly, so the majority of the face, and that's because it receives like the facial vein here. Cool. You definitely need to know this part. Think about cavernous sinus thrombosis when you think about like facial vein and things, because it communicates with your superior ophthalmic vein, and that goes directly into your cavernous sinus. You're also worried because these veins in the face, as well as your cranium, are valveless. And so you're worried about an infection risk when you have an infection of the face, that it would travel to your brain. These are your lymphatics. Half of the lymph nodes in the body line the head and neck. When they say, oh, someone's coming with an enlarged hard node, you're thinking cancer. When they say enlarged and tender node, you're thinking more infection. And generally, the nodes in the face, the important ones are submental, submandibular, preauricular parotid, and these drain into your deep cervical group. And then two other important ones would be your Virchow's node or your supraclavicular node, which drains your intra-abdominal and thoracic organs, classically related to gastric cancer, a little bit of a buzzword. And then you've got your jugular digastric lymph node or your upper cervical, which is your tonsil. So will be enlarged with a sore throat, for example. Cool. This is innervation of the head and neck. Thank you to Alina for lots of these. So your head and neck is largely supplied by your cranial nerves. You've got a couple glands in there, such as your lacrimal gland, some nasal ones, and salivary glands. These have autonomic innervation, so they need PNS. Your parasympathetics make them secrete, and then SNS does the opposite. All your SNS comes from the roots in the thoracic region. They feed into your sympathetic train, go up, exit via T1, and then travel on like blood vessels, plexi, plexuses to reach their destination. And then you've got your cervical plexus, which I mentioned before, with some cutaneous and muscular innervation to the neck. This is a cranial nerve summary. You've got 12. They can be sensory or motor. Yeah. And this is a summary of their functions, curated by the lovely Alina. So running through them, your first cranial nerve or your olfactory nerve, in charge of smell, easy peasy. 2, optic, vision, awesome. 3, oculomotor, and these are basically most of your eye muscle movements as well as pupil constriction. And then 4 and 6, also part of your eye, is so for LR6. So superior oblique for your trochlea, lateral rectus for your abducens. Your trigeminal, doing facial sensation, as well as the anterior 2/3 of your tongue in terms of sensation, and does your muscles of mastication. Your facial nerve does your facial expressions. It does gland secretion, so it's got lots of PNS. It's got anterior 2/3 of the tongue in terms of taste and some sensation in the external ear. Vestibular cochlea is with hearing and balance. Glossopharyngeal or CN9 gives you a lot of random things, but like it does the posterior 1/3 of your tongue in terms of both taste and sensation. It does your parotid gland secretions and some other things like your staphypharyngeus and things like that. Vagus nerve, classically your GIT, which I'm sure you've learned lots about already. It does your ear, larynx, pharynx sensation, lets you talk, some muscles, some sensation. And then accessory nerve, your traps and your sternocleidomastoid. So remember in your cranial nerve exam, you're like, oh, please stroke your shoulders, please turn your head. Accessory nerve. And then hypoglossal does all your tongue muscles except for palatoglossus. Cool. These are the origins. So CN1 and 2 come from your big brain, so your cerebrum. The rest come from your brainstem. So CN3 from your midbrain pontine junction, that's your midbrain, that's your pons. CN4, your trochlea coming from behind. And by the way, this is an anterior view, so you're looking like at someone. This is trigeminal from your pons, and this one is obvious because it's thick. And then you've got a couple coming from the pontine medulla junction, 6, 7, and 8. 8 often you can actually see the 2 branches, pretty cool. And then 9, 10, and 11 come from the medulla, posterior to the olive. And then CN12 comes from the medulla anterior to the olive. This is your trigeminal nerve. So I'm only going to go through kind of the harder ones briefly, but you can see that it's supplying sensation in terms of this. I kind of try and remember the lines-ish. You can see here that there's lots of PNS hitchhiking with the trigeminal. So from the facial nerve, it hitchhikes and supplies the lacrimal gland. From the facial nerve, it hitchhikes and supplies the nasal mucous glands. So the PNS actually comes from facial nerve, and the trigeminal nerve is just used as like a highway. The auriculotemporal nerve supplies PNS to your parotid. And then your lingual nerve over here gives sensation to the anterior 2/3 of the tongue, as well as allows the chorda tympani to hitchhike and supply the anterior 2/3 of the tongue. Your motor root supplies your muscles of mastication, as well as a few other ones like tensor tympani, tensor veli palatini, and your suprahyoids. In terms of pathology, you can get trigeminal neuralgia. So this is a chronic neuropathic pain over these distributions. You've got two types. You can have hyperalgesia, which is increased sensitivity. You can have allodynia, which is pain from non-painful stimuli. And it's caused by nerve damage. Treat it with carbamazepine. Herpes zoster, or HSV, is a viral infection. It lies dormant and latent in the trigeminal nerve ganglion. And then when it reactivates, maybe they'll get sick, maybe they become immunosuppressed. It reactivates and it becomes shingles, and you get these blistering vesicles in that distribution as well. Cool. That's trigeminal nerve. This is facial nerve. Big things. Muscles of facial expression. Taste to the anterior 2/3 of the tongue via the chorda tympani, which also supplies PNS to your salivary glands that lie here. We'll go through that a little bit more. Checking time. Yeah, so that's the PNS. You also have PNS to the lacrimal mucus glands of the upper respiratory tract. Other than that, yes, and it's related to the facial canal, which is quite important, which is close to your middle ear. Extracranially, it gives off a couple branches posteriorly and inferiorly, and then the rest of the nerve continues into the parotid gland, and that's important. And that terminates by splitting into 5 branches: your temporal, zygomatic, buccal, marginal mandibular, and your cervical, to supply your muscles of facial expression. Yeah. So facial nerve palsy. Symptoms depend on where the palsy is. So if it's only in this extracranial course, then you're just thinking motor weakness and paralysis, because you can see that all of these things just do motor things. If it's intracranial, then it can affect the things before that. So all of these things here. So that can include loss of salivation and taste, loss of lacrimation, for example, as well. Differentiating Bell's palsy from stroke. The easy way to remember is stroke is forehead sparing, and then that's basically all you'll ever be asked. But if you'd like to know why, it's because you have bilateral innervation of both. So you can see that it comes from both sides, and then they kind of join together in your facial nerve to supply your whole face. So if you cut off one half of the brain via a stroke, then the second half or the other, the opposite side of your brain can still come down and supply the whole face, more or less. But if you cut it off at the facial nerve, then you cut off both branches, and so you, facial nerve, you cut off both branches, and so there's forehead paralysis as well. Vagus nerve lesions, know that your uvula deviates away from the side of the lesion. And for cranial nerve 12, I guess it's not on the slide, but your tongue goes towards the lesion. Paralysis of the vocal cords will come to a little bit later. Cool. This is your parasympathetics again. So COPS 3977 and 10 to the rest of the body. So 3 preganglionically is your oculomotor nerve, goes into your ciliary ganglion, travels via the short ciliary nerves and goes to your pupillary sphincter. Cranial nerve 9, preganglionically is your lesser petrosal, goes through your otic ganglion, hitchhikes with your auriculotemporal and goes to your parotid gland. And then everything else is from facial So greater petrosal and quarter tympani to the lacrimal gland and the salivary glands. Eye and vision. All right, we're up to the special bits. How are we doing for time? Ooh, okay, I have to speed up. There are three major openings in the orbit. You've got your optic canal, your superior orbital fissure, and your inferior orbital fissure. So your optic canal has your two most important things, your optic nerve and your ophthalmic artery. And I like to remember this image, and you can see both of them are in there here. These are your fissures and things. So other than that, all the important things come from your superior orbital fissure. So that includes your oculomotor nerve, your trochlear nerve, your superior ophthalmic vein, and some branches of U1. And then all like the kind of not important things come from your inferior orbital fissure. No one will ever ask you about them. Yeah, blowout fractures is this essentially when you blow out a part of the eye, often due to blunt force trauma. Cool. Eyelids. They function as protection mainly and distributes tears. The upper and lower lids meet at the medial and lateral xanthi, and the opening in between is the palpebral aperture. You've got 4 layers. Firstly, your skin and subcutaneous tissue, then your orbicularis oculi muscle, which is the one that goes around the whole eye. Then you've got your tarsal plates, and then your conjunctiva, which forms a layer. These are the arterial and venous drainage and the innervations. All right, so eye muscles. Important to know that it's slightly off center. I wouldn't say it's extremely important to know all the details of how that affects everything, but you should know the results and how to interpret like clinical testing, etc. So you've got superior and inferior obliques, as well as superior medial lateral and inferior rectus muscles. And the way I remember the movements is, and this isn't clinical testing, this is just normal movement. All rectus will adduct, like go inwards, except your lateral rectus, and that's because it's lateral, so it's going to abduct. And along with the lateral rectus, the obliques will also abduct. Your superior inferior rectus will elevate and depress as with the name. So the superior will elevate, inferior will depress. The obliques always do the opposite. So the superior oblique will actually depress the eye. And then superior oblique will internally rotate and the inferior will do the opposite. In terms of clinical testing, it like kind of swaps, like where the obliques and rectus are will swap. So you can see, and that's because you've kind of moved from where it goes from. You're not just kind of going that way and going up. You've actually moved the eyeball to the side. So once you've moved it to the side and you've abducted it, then when you go up, you're using your superior rectus because it's going straight up. And then when you go down, you're using your inferior rectus. So that's how I remember it. And then the obliques are just flipped. So the inferior is up the top and the superior is down the bottom on the other side. In terms of innervation, you've just remember, so for LR6, all else 3. But 3 has 2 divisions. You've got your superior and your inferior division. So superior does your superior rectus and levator palpebrae superioris here, which kind of works on your eyelid. And then your 3 inferior does your inferior medial rectus and your inferior oblique. And they kind of run like this. This is your eyeball. It's got 3 layers, fibrous, vascular, and inner. So your fibrous layer is your sclera, or the white part, and then as it goes in front of your pupil, it needs to become clear, so it becomes your cornea. And then I just remember the inner layer is the retina, and all else is the vascular layer. So your vascular layer is composed of your choroid that turns into your ciliary body, which is muscle, which attaches to your iris, which is the colored part of your eye. And then you've got your pupil in the center. And then your retina is, what lets you see. You've got layers to the retina. I think we might have been tested on this before. So you've got this So this is a sclera, this is a choroid, so you can kind of think this is more outside, this is more towards the inside of the eyeball. You start with your nerve fiber layer, that becomes a ganglion cell. And then you've got an inner plexiform layer here where it kind of joins with the next cell, which is a bipolar cell. And that's the inner nuclear layer. And so yeah, that attaches with the inner plexiform and the outer plexiform. And then you've got your photoreceptor cell here. You can see all the little nuclei, and that's the outer nuclear layer. So you can see you've got an inner and an outer nuclear layer based on these two extra cells. And then the outer nuclear layer has to go into the receptor layer where you've got your photoreceptors. Yeah. You've also got some special parts of the retina. So you've got your fovea, which has high concentrations of photoreceptors, and your optic disc, where your cranial nerve 2 enters, and so there are no light detecting cells there. Other structures in the eyeball, you've got anterior and posterior chambers. This is not your posterior chamber. Don't say this is your posterior chamber. This is your posterior chamber. So they're the little ones. This is your big, like, vitreous chamber. Both of these, the anterior and posterior, are filled with aqueous humor, and that's just fluid that nourishes and protects the eye, and it's constantly made and drained. If it doesn't drain, bad things happen. You've got your lens, and then vitreous humor in the chamber. It's supplied by your ophthalmic artery from your internal carotid. As I mentioned before, the internal carotid does the brain and CNS apart from the ophthalmic, because it comes here to your eye. And then venous drainage is via superior and inferior ophthalmic veins, and they're actually usually 4, so boom, 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 like that. Optic nerve, this is high yield. So how do you see? Well, you detect things from your eye, runs through your optic nerve, goes through your optic chiasm, and then kind of comes here to your lateral geniculate body. And then you have 2 optic radiations on either side. You have one that goes superior, one goes inferior, kind of in your parietal and your temporal lobes. And then they all end up at the back in your visual cortex of your occipital lobe. Super important. You can see that the left side, things that are on the left go to the right side of your brain and your eye. So it goes to the right side of your eye, goes to the right side of your brain, goes to the right side of your occipital cortex. And this is just 2D, so up goes down as well. So things that you're seeing that are like up there travel in, and then via the opposite side of the inferior optic radiation. So things that are up go down in your brain, things that are left go right in your brain. So flip them up, down, left, right. So we'll go through kind of some of these. If you hit your optic or your retina right there, you get a central scotoma, exactly just where that is, in the right eye. If you hit your optic nerve, then you don't see anything from this eye, and so you get vision loss from one eye. But remember, the whole picture is still there because you can still see with your other eye. They love this one. So if you hit it at the optic chiasm, you get bitemporal hemianopia. And that's because you're receiving this vision from, say, the right, from both eyes, and then they both just go to the right side, right? Well, actually, the picture will be the left, but it hits the right side of your eye, and that goes to your right. And that's the same thing for the left. And because you have that crossover, when you hit it in the middle, you can see that it's these middle fibers that are kind of hit. And these middle fibers by your nose actually look at things that are not in the middle, right? Because switch left, right, up, down. So they look at things on the sides. So that's what you call bitemporal hemianopia. Temporal for temporal on the side, bi for both sides, and hemianopia, hemi for half. So half your vision lost on the temporal sides in both eyes when you hit the optic chiasm. D is when you hit that kind of later optic radiation that hits just one side of your vision, is completely gone. if you hit the superior optic radiation, you lose that inferior quadrant. So upper right, you lose bottom left, essentially. That's that one. And if you hit the upper or the bottom right, then you hit the upper left. And then the last thing to note is when you hit the occipital lobe, you actually get macular sparing, hemianopia. So you hit off one whole side, right? Because as you can see, it's all pink here, it's all pink here, it's on one side. But I think, yeah, you spare the macula because there's some compensation of that on the other side, I think. Innervation of the eye. CN2 or optic nerve does your vision, so you get visual loss. CN3 does oculomotor. Yeah, so that's got some PNS. So it constricts your pupil and it makes your lens more spherical by contracting the ciliary muscles. So the ciliary muscles actually are weird because they're arranged radially, right? So when you constrict them, it actually relaxes the little like ligaments, I guess, that hold your lens. And because they relax, your lens is more spherical and it's not as stretched out. It raises your eyelid via the superior tarsal, and it does most of your extraocular muscles. So when CN3 is hit, you go down and out. If you have to remember one of these, remember down and out. But you also get like ptosis, so drooping of the eyelid, and dilation of your pupil. So your trochlea does your superior oblique, so people tend to compensate by like tilting their head away. And then your abducens nerve does your lateral rectus, and so the affected eye turns inwards because the lateral rectus isn't pulling outwards. When you hit your sympathetic trunk, you classically get Horner syndrome, so ptosis, meiosis, and anhidrosis. And that can be affected by Pancoast tumor. And that's a tumor at the apex of the lung because it just kind of compresses your sympathetic trunk there. This is your lacrimal apparatus. PNS comes from your facial nerve, follows the greater petrosal to the pterygopalatine ganglion, and then hitchhikes with zygomatic branch of the maxillary nerve. SNS inhibits secretion from the superior cervical ganglion, traveling via all your like blood vessels. So lacrimal fluid, aka tears, are secreted into excretory ducts, which empty into the superior conjunctival fornix. When you blink, it's really cool. When you blink, it kind of does like a wave thing. So it pushes all the tears towards the inner corner. And that's where you call it the lacrimal lake, so the tear lake, in the medial xanthus of the eye. That drains into the lacrimal puncta, or the holes, which turn into the canaliculi, or the tubes, into sacs, or the lacrimal sac. And then that goes into your, nasolacrimal duct and drains into the inferior meatus of your nasal cavity. And that's why you get snotty when you cry. Pathology of the eye. This is quite like a broad summary, but glaucoma is when you obstruct the drainage of aqueous humor. You can get open angle or closed angle. When it's open angle, the drainage is reduced. So you get gradual reduction of peripheral vision. Closed angle is when there's no drainage. And that's because it's just done this. It's done, there's zero chance you're getting into that trabecular meshwork. That rapidly leads to blindness. It's very bad. Cataracts is opacification of the lens in old age. You might have, a grandparent who has cataracts. Papilledema is swelling of the optic disc due to raised intracranial pressure. And you can see that kind of here. Diabetic retinopathy is a microvascular complication. And so you get these scotomas or blurry patches, and you get loss of acuity. Macular degeneration is a chronic degenerative disease of the retina, and that leads to progressive loss of central vision. This is near and farsightedness. I think the biggest thing to take from this is nearsightedness equals you can't see things from far away, so you can only see things that are near, and that's when your lens is too rounded. Farsightedness or hyperopia is the opposite. And then normal accommodation is happens via your ciliary muscles. So as I mentioned before, your ciliary muscles are radial. And so when they contract, your suspensory ligaments relax. That's the ligaments that hold your lens. These ones, you can't see them very well. But they relax. And because they relax, your lens becomes thicker because it's not as stretched out, and that gives you good near vision because there's more refraction. And the opposite is true. Cool, we're done with the eye. Now, the upper respiratory tract. Ooh, half an hour, we got this. These are connected bits. You have your nasal sinuses, which drain in, nasal sinuses are these guys. So you have frontal, you have your ethmoid, you have your maxillary, and you have your sphenoid at the back here. These all drain into your nasal cavity or your nose. And then your middle ear is actually connected to your nasopharynx as well via the eustachian or the pharyngotympanic tube. There's an ambulance. You have your oral cavity and your nasal cavity, which I'm sure you know well, and those are separated by your hard and soft palate. So your hard is when you've got actual bone there, and then your soft is just kind of muscular and soft tissuey. Your pharynx is at the back, turns into your esophagus at C3 and 4. So that forms your nasal pharynx behind your nose, your oropharynx behind your oral cavity, your mouth. Don't worry about hypopharynx. And then your larynx turns into your trachea at C3 to 4 as well. And that's your epiglottis there, which can open and close this so you don't breathe in your food. Starting with the air. So reminder of these relations, goes into the nasal cavity via the pharyngotympanic tube in terms of the middle ear. Externally, you have the external acoustic meatus or your ear hole, and your cranial cavity via the temporal bone. Well, it's separated by the temporal bone. Cool. So you've got your outer ear, your middle ear, and your inner ear. Bony part is all in the temporal bone. And as a brief overview of function, sound waves move the tympanic membrane, which moves the ossicles in the middle ear, which amplifies the vibrations, to move fluid in the cochlea, which goes whoop, 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 and through into the vestibular nerve, vestibular cochlear nerve. Yeah. So starting with your external ear, skin cancers present often at the helix, which is here. I don't know why I started with that point. You've got your auricle and your external acoustic meatus. So external acoustic meatus is just like the hole and the first part of like the tubing. And then your auricle is actually the bit that you can grab. So in terms of your auricle, you have your helix, which has some parts. You've got an antihelix, which is like a helix, but it's on the inside. You've got your lobule, and then you've got your tragus here, which some people use to like block their ears. And then you've got an antitragus kind of close by, and an intertragic, intertragic notch. Anything else that's important? No. Cool. In terms of the external acoustic meatus or the actual path, the outer 1/3 is cartilage, the inner 2/3 is temporal bone. When you're examining, you want to pull upwards, posteriorly, and outwards because of the way it's kind of situated. You should remember that. And then it's partially innervated by the auricular branch of the vagus nerve, and that's what causes fainting during air washing. Other than that, I don't think you should. It's innervated by a lot of nerves, so I wouldn't expect they would want you to know all of them. This is your tympanic membrane. You've got some parts of it. Pars flaccida is the small part. Pars tensa is the big part. Cone of light is important because it shows that it's the right, it's got the right tension on it and nothing's pressing on it from behind, for example. You can see the handle of the malleus over here, and that ends in the umbo. Nothing else is that important. Innervation, mainly by the auriculotemporal nerve. Yeah. That's basically it. Try not to perforate it. Middle ear. This is the interesting part of the ear. It's, maybe the internal part, but it's in the temporal bone. Consists of your tympanic cavity and your epitympanic recess, epi for up, so it's above that. And it communicates with a couple areas. So it communicates with your mastoid area behind your ear, which has your mastoid ear cells. And because the mucous membranes are continuous, infections can spread from your middle ear to your mastoid process. It's also connected to your nasopharynx by the nasopharyngeal, nasotympanic or eustachian tube here. And that functions to equalize pressure across the tympanic membrane. And that's why, people can kind of hold their nose, blow through it, and that equalizes pressure. It's also surrounded by like cartilage and the tensor veli palatini muscle, which usually elevates your soft palate, right? So it's contracting when you swallow. That also opens up the tube. So next time you're on a plane, pressure changes, you can try swallowing. Your tensor veli palatini will elevate your pharyngotympanic tube and equalize that pressure in your middle ear, make you a bit more comfortable. In terms of contents, it's got your ossicles, so your malleus, incus, and stapes. Main thing to know about that is the head or the malleus that attaches to the tympanic membrane, and it's the oval base that attaches to the oval window on the stapes. You've also got two muscles. You've got the tensor tympani, which tensors the tympanic membrane, pretty well named, and you've got the stapedius, which attaches to the stapes, and that prevents excessive oscillation during loud noises. Yeah, so it's kind of making sure that your ear doesn't vibrate too much. All right. Your middle ear, this is the room. So this is, it was a pain to learn, but you need to learn it. For me, this was kind of actually hard, almost harder to remember than this, because you actually have some kind of awareness of what the structures are in relation to everything else. So learn it how you will. But I guess to run you through very briefly, you have your end, and it's important to orient yourself. So this is looking, say, like at someone's ear. So you're basically the tympanic membrane. You're looking like into the depths of their head. This is anterior, so towards their nose. This is mastoid, so posterior, towards the back of their head. I can take you through it. I don't think it's really worth it, to be honest. Tegmental is mainly just your temporal bone. Anteriorly, you have your pharyngotympanic tube, your tensor tympani muscle. You've got your branch from your internal carotid plexus, your sympathetic plexus. You can see it's all here on your internal carotid artery. Underneath, obviously, you have your internal jugular vein over here. Your facial nerve also has branches that come up. And you can see here that the facial nerve goes up and through it almost via the facial canal. And that's important because you can hit your facial nerve via your middle ear. And then, what else is there? That's basically important things, I think. Yeah, just learn it. Cool. Pathology. Otitis media is infection of the middle ear. Is common in infants and small children. It's mostly viral, so RSV. And they often get like fever, earache, maybe some discharge, usually self-resolving. It can cause perforation of the tympanic membrane because you're building up kind of like pus and things like that behind it. And it can also spread to your mastoid process and cause mastoiditis. And that looks like that. And mastoiditis is very bad, basically. I think if they were to give you an exam question, they'd only ask you what it is. So mastoiditis behind the ear. Maybe they had some otitis media before that. This is your internal ear. So the most inner part of your ear, it's in the petrous part of the temporal bone. And it contains some structures for hearing, i.e. the cochlea or the snail-like region, and balance for your vestibular system, which has these semicircular canals. The nerve responsible is your vestibular cochlear nerve, well named CN8. and it's got a bony labyrinth and a membranous labyrinth. So this is like inside of that. Your bony labyrinth is lined with periosteum because it's bone, and it contains fluid called perilymph. It's made up of the vestibule, 3 semicircular canals, and your cochlea. Your membranous labyrinth is filled with endolymph, and you've got the vestibular system as well as your cochlear duct. So this is your cochlea. We're starting with this part, which is in charge of hearing. So the bony labyrinth, this part, not this part, contains passages for your cochlear nerve. Yep, that's not important. Membranous labyrinth is here. That contains your endolymph. And the membranous labyrinth actually splits the tube into 3 segments via the vestibular membrane here and the basilar membrane here. That gives you the central canal called the cochlear duct. And this is where your endolymph is. It runs from the oval window, from where your stapes is attaching, all the way to the apex. And so when your stapes is kind of like vibrating on this oval window, it moves the endolymph inside this cochlear duct. And that's detected via the spiral organ of Corti. And that transits, and you can see it's got little like wiring things that transmit signals to the cochlear nerve here, and that goes up and into your brain. The other 2 ducts are continuous at the helicotrema and contain perilymph. You've got the scala vestibuli and the scala tympani. Not too important. Cool. So that's all for hearing. This is the vestibular system, so this is for balance. You've got your 3 semicircular canals, anterior, posterior, and lateral, positioned at 90 degrees from one another. And different parts detect different types of acceleration. So your ampulla, it's a bit hard to see here, but it's this bit that kind of bulges out at the end. That detects rotational acceleration. And then these all empty into the utricle, which detects, where is the utricle in there? It's a bit hard to see. Utricle is here. Detects vertical acceleration. And then the cochlear duct empties into the saccule, and that detects horizontal acceleration. So ampulla, rotational, utricle, vertical, saccule, horizontal. Yeah, labyrinthitis is when you get inflammation of these semicircular canals, and they become very disoriented, but it's pretty short-lived. I thought I'd go through René's and Weber's really quickly here. So this is your tuning fork tests. Essentially, there are 2 types of hearing loss. You can get conductive or sensorineural. So conductive is, it sounds weird because you're like, what kind of conduction? Just think of it as like something blocking your ear. So if you like block your ear with your finger, or if you have a large earwax, if you have bone there, if you have a tumor there, that's conductive hearing loss. Sensorineural is something wrong with the nerve itself. So when you do René's and Weber's, you do René's first. And I don't know how you guys remember which is which, but I think like of someone's face and like the R's are making up the ears, and then Weber makes up like a little crown. So you know that René you have to do on both sides of the ear. So you tap your tuning fork, you place it behind their ear. You ask, tell me when you can't hear this. They're like, okay, I can't hear it. Then you move it in front of their ear. You say, can you hear it again? If they can hear it again, that's normal or sensorineural. And that's because your air conduction should be better than your bone. That's why you have an ear. Otherwise, you would just hear things through your bone. Otherwise, if you can't hear it again, then it's conductive loss because you can't hear it through the ear. So something's blocking it. And then you do your Weber's. You hit your tuning fork, place it on like their forehead region, and you ask, does it go to one side? And if it's conductive, then the sound will lateralize towards the bad ear, so the blocked ear. And the way that you can remember that is if you say block one ear and you start talking, then you notice that sounds kind of go that way, and it's blocked. But it sounds louder on that side. Sensory neural is the opposite. So yeah, there's another table there. This is Elena's slide. She's brilliant. Take another look and make sure you know this because they ask you. Cool. This is your nasal cavity. How much time do I have left? 15 minutes. Okay. Oh, all right, straight into it. You've got your external nasal skeleton made up of a couple bones. You've got your choana, which is what goes into your pharynx. This is your nasal skeleton. It's got lots of bones. Kind of talked about them before. Remember your inferior nasal concha is a separate bone. Yeah, and then under these superior and inferior, or under these concha, you have superior, middle, and inferior meatus. Things that enter and exit your nose, starting with the nerves. Sorry, it's a little messy. This is your sphenopalatine foramen, and your nasopalatine nerve comes through here. It's in the name, so it goes from your nose to your palate through your incisive canal. Yep, and then your cribriform plate up the top contains your olfactory nerve fibers, as well as anterior ethmoidal nerve, which is like a sensory nerve. Around your nares, you have internal nasal branches of your infraorbital nerve, and then you've got other small foramina too. These are your arteries. So this is your sphenopalatine artery. That's a big one that kind of goes forward from the same. Oh yeah, and that has like lots of like big branches and things like that. Your greater palatine artery, remember, comes from your greater palatine canal foramen that goes up through your incisive canal into your nose as well. Got your nasal artery coming from here, and then you've got anterior and posterior ethmoidal arteries. These are your nasal sinuses. The drainage is high yield. So remember, you've got frontal, ethmoidal, sphenoidal, and maxillary sinuses. And the easiest way to remember how everything drains, I find, is to think about the recesses. So sphenoethmoidal, or above the superior concha, drains the superior the sphenoid sinus over here. Your superior meatus over here under the superior concha. Over here, actually, it's usually tiny. It's a little bit hard to see. That drains your posterior ethmoidal cells. And then you've got a middle meatus, which is huge. And that's got a semilunar hiatus under it, which drains the frontal sinus from here, as well as your anterior ethmoidal cells and your maxillary sinus from here. And then you've got openings on the ethmoid bulla for the middle ethmoidal cells. So far you can see we've done the anterior ethmoidal from your semilunar hiatus, moving to middle ethmoidal, moving to posterior ethmoidal. They're actually kind of in a line. And then under your inferior meatus, you have your nasolacrimal duct for your tears and your pharyngotympanic tube, which is almost not under it. It's a little bit cheating, but that's where your middle ear is. Oral cavity. Okay, so these are some structures, as I mentioned before, mylohyoid, the geniohyoid. Big thing to take from this is your sublingual and submandibular ducts are kind of there, so glands. So sublingual is here, submandibular is here, and your lingual nerve, bing bing, runs underneath your submandibular duct. Here. Important to remember that because of surgery and things. Okay, these are your soft palate muscles. They're all innervated by the vagus nerve, except the pharyngeal branch to the via the pharyngeal branch to the pharyngeal plexus, except the tensor veli palatini, which is supplied via the mandibular nerve. So these are the muscles. I really like this picture. It's got your palatoglossus right here, palate and glossus, so tongue, runs between those two. And then you've got your palatopharyngeus muscle behind that, because palate and pharynx. Between that, you have your palatine tonsil. Yeah, cool. Tensor veli palatini, you can see is here. And then you've got your levator veli palatini as well. Both elevate the soft palate, as you can see, because it's above it, but only the LVP elevates it above neutral. think levator, to elevate. And that's because the TVP wraps around the pterygoid hamulus before attaching to the palatine aponeurosis. So you can see it here. So it goes like this, from the top, wraps around the hamulus and then attaches to your soft palate. And that means it just can't really elevate it above neutral. You've also got the musculus uvulae, which pulls the uvula superiorly. These are your tongue muscles. They're all paired. You've got intrinsic and extrinsic muscles, and they're all supplied by the hypoglossal nerve, except for palatoglossus by the vagus nerve. So your intrinsic muscles alter the shape of your tongue. That's what lets you roll your tongue, curl it, move your food around. And then your extrinsic muscles are here. So you've got your genioglossus. Think about the name. Genio for chin. So that goes from your chin to your tongue. You've got your hyoglossus. So that goes from your hyoid bone, your styloglossus from your styloid process, and your palatoglossus from your soft palate. So, yep. Cool. Important relation, from inner to outer, you have your genioglossus, your lingual artery, then your hyoglossus, and then your hypoglossal or lingual nerve. Sorry, I'm going a little faster, guys. I'm trying to finish. These are your vessels. So you've got your lingual artery, and then at the back, it's kind of your dorsal lingual, and then it goes to your deep, and then sublingual. And these are all your arteries and veins. Innervation is high yield. So all the musculature of the tongue is via the hypoglossal nerve, apart from palatoglossus via the vagus nerve. For sensation of the anterior 2/3, your trigeminal supplies the general sensation, and your facial nerve via the chorda tympani supplies taste. Posterior 1/3, glossopharyngeal, does everything in terms of sensation. And then everything else, like the epiglottis, soft palate, that's done by the vagus nerve. So uvula deviates towards the normal side, tongue deviates toward the abnormal side. Again, just to repeat the important bits. These are salivary glands. So parotid, sublingual, and submandibular under the mandible. Important relations of the parotid gland: it's pierced from superficial to deep by the facial nerve, and it turns into the 5 terminal branches, the retromandibular vein, external carotid artery, and lymph nodes. So if you really hit your parotid gland bad, you're thinking, oh, maybe they'll get tingling, maybe they'll become, well, they're not really tingling, but maybe they'll become paralyzed on that side of the brain. And then, yep, that opens to your second upper molar, and it's supplied by a glossopharyngeal. And then submandibular gland, as mentioned before, the lingual nerve loops under that duct, and the facial artery actually loops over the superficial lobe. It opens to your sublingual caruncle behind the frenulum, which is that middle bit when you lift your tongue up. And then the PNS for both the submandibular and sublingual gland is via the chorda tympani of the facial nerve. Mumps is a viral infection that affects the salivary glands, most commonly the parotid gland. So facial nerve injury will give you difficulty with facial expressions. And you can also get localized ear pain, and they get very swollen. Pharynx. Okay, structure. So you've got your nasal cavity that goes into your nasal pharynx via your choanae. Got your oral cavity that goes into your oral pharynx by your oropharyngeal isthmus. Your nasal pharynx and your oropharynx is separated by the pharyngeal isthmus, and that turns into the larynx, the trachea and the esophagus and the pharynx. So if you elevate your soft palate, you can see that you close the pharyngeal isthmus and you isolate kind of the nasopharynx from the rest. And your epiglottis can close the laryngeal inlet and isolate the larynx. These are your tonsils. They form the Walder's ring. Pharyngeal muscles. Okay, not too important. You have your constrictors, which is like a telescope with your inferior most outside, and you have your longitudinal. They're all innervated by branches of, the pharyngeal branch of CNX, vagus nerve, except for stylopharyngeus. which is innervated by the glossopharyngeal nerve, which also, that same nerve, provides most of the sensory innervation to the pharynx. So when you're thinking pharynx, you're thinking 9 and 10. 10 mainly making you swallow, and 9 mainly sensing that food going down. Pharyngeal spaces, the most important thing is your danger space. That's this in green right here. It's posterior to your retropharyngeal space, and that's a potential path of infection from your pharynx to your superior and posterior mediastinum. Here, where your heart is. All right, larynx. Oh, 7 minutes. Cool. Larynx makes you sing. The most important structures would be your hyoid bone, your thyroid cartilage, your cricoid cartilage, your epiglottis, and then these little guys. So you've got 2 arytenoids, which kind of move your vocal cord. You've got your corniculate cartilage, and you've got your cuneiform, which is like in the ligament. You can't see it very well. You can see your thyrohyoid membrane here, and your cricothyroid ligament here. These are your ligaments. I'd say the quadrangular membrane is this big one that kind of runs from your epiglottis to your thyroid cartilage. But the important one to remember is your cricothyroid ligament forms your vocal cord, or true vocal cord, rather than your false. And that eventually forms like the structure here. It forms a hole, which is called the rema glottis. Yeah. For more details, go to Pierce Panda. Laryngeal muscles are all innervated by the vagus nerve. The cricothyroid by the external branch of the superior laryngeal nerve. All others via the recurrent laryngeal branch. They actually ask this quite a lot, for what it's worth. The cricothyroid tenses your vocal ligament. Your vocalis and thyroarytenoids sit next to your vocal cord, and so it relaxes them. Your posterior cricothyroid abducts your arytenoids to open up your vocal cords, and then all the other ones closes. Neurovasculature, coming towards the end. Okay, so I like to think about this via superior and inferior branches. This is actually really good to remember. So you have things coming from up and you have things coming from down. In terms of arteries, the superior portion is supplied by your superior laryngeal arteries, the inferior by your inferior laryngeal. Same thing with veins. Perfect, lovely, named well. Lymph nodes, superior deep cervical and inferior deep cervical. Awesome again. Nerves. So this all comes from your vagus nerve. Your vagus nerve comes down and it splits into superior laryngeal and kind of like a recurrent laryngeal. Yeah. So your superior laryngeal comes off first superiorly. It supplies this, and then it turns into your external branch to supply your cricothyroid muscle and your inferior constrictor of the pharynx. And then all the rest goes inside as the internal branch, and that just does sensation inside down to your vocal folds. The recurrent laryngeal branch goes all the way down, and then it goes up again. And that does sensory below the vocal folds. It does motor to all the other muscles. And so that's basically all of the laryngeal muscles. And you have to notice that it loops around either the arch of the aorta on the left or the subclavian artery on the right. So when you do a thyroidectomy, what are the structures at risk? Your external superior laryngeal nerve over here will make the cricothyroid weak, and that gives you a weak voice. Your recurrent laryngeal nerve does all the other muscles. So if it's unilateral, you get a hoarse voice. If it's bilateral, you're not speaking. Your parathyroid glands on the opposite side of your thyroid will cause hypocalcemia. And one thing you're really worried about is post-thyroidectomy hemorrhage. So that's basically after thyroidectomy, you're really worried that it's going to bleed a lot. And because of all that fascia in the neck that we talked about before, you're worried about airway obstruction. And that's why when people are post-thyroidectomy, lots of times they'll have like a little undo the sutures kit next to them. So they might actually have to have their neck open on the wall to relieve that pressure, to allow them to breathe, essentially. Embryology. So I realize your next lecture is going to start now. So I might just let you have a 2-minute break. Gavin did this really well with Pierce Vander, so I'm sure you can, and he was pretty quick as well. So I'm sure you can just watch that. If you have any questions, send me an email or hit me up on Facebook. Otherwise, yeah, good luck everyone. Thanks for coming.
Thanks very much. So everyone, all the slides are also on the Google Drive as well, so you can find those slides and read through them. All right, thanks very much.
Cool.
See you in the
Good
next
luck, guys.